There are two things that are happening today, and people's hearts are fluttering up and down, jumping, doing a thing, because maybe something will happen, maybe it will not. Don't fight with anybody because they might bring you that. So that's happening. We're also having a Healthy Friday conversation today. And so we've decided that, okay, fine. As we're having a Healthy Friday conversation, let's take into consideration, as the judges do, the atmosphere, And now let us wrap that Healthy Friday conversation around the heart. And we'll be discussing matters of the heart today. And our guest is already in the studio. Dr. David Githanga is here. He's a consultant pediatric cardiologist and a public health specialist, and he's here to discuss matters of the heart with us today. Boom, boom. Good morning, Dr.
Good morning, Ju. How are you?
Very well.
I almost want to ask him whether he fixes broken hearts.
Don't worry. That's why he's
That's
here.
why he said almost. Almost.
That's why he's here. Don't worry, Mark. Your issues will be sorted. Dr. is here today. So, don't be shy. Don't be shy. Dr. Good morning.
Good morning, Ju.
You're well?
Very well, thank you.
Good. Yes. So you're going to fix Mark's broken heart today, and then also tell us how you fix others. But before you do that, how about we welcome you to the show with Proverb. So CT, as you know, he skips about, and he's got very interesting ones this week. So let him tell you what that is, and then you can interpret that for us.
Yes, we've been in the Republic of the Gambia. I still get tickled in the Gambia.
Yes.
Not the Kenya,
have to introduce themselves.
Not the Tanzania, but the Gambia. He who weeps in the morning knows what makes him weep.
Wow. He who weeps in the morning knows what
makes him weep.
I guess what comes straight off my head is you really know why you're crying. I mean, the reasons are there. Another person looking at you may not know, but you deeply know.
Mm-hmm.
Yeah.
You know.
You know.
Okay. So we're getting into it this morning. A Healthy Friday conversation, is really matters of the heart. And just looking at an overview of some of the diseases that do affect the heart, or some of the conditions of the heart. And in most cases, stop me if I'm wrong, but they're called non-communicable diseases, right? Okay. So if we can get into that, please do tell us, heart health as a country as a whole, what are you seeing really that would maybe have you worried or have you impressed or make you want to do a little bit more to make sure that, we keep some of these things at bay? Give us an overview.
Yeah, thank you very much. It's interesting that we should be talking about the heart on the
I have to tell you, the maestro of these things is sitting to your left. Yes. And where's your left?
His other right.
His other left. So
he's sitting to your
brilliant.
left.
I must debunk the theory that the heart is a seat of love and things like that. It's really just a pump. It's just the most efficient pump in the world.
Bacteria was most dumped and my physical heart hurt.
Yes, the heart is just a pump, the most efficient pump that after fertilization, in about 3 weeks, you can actually identify the heart's activity. And it bangs away the whole of your life until you die. So it's really effectively just a pump. Yeah, but it's interesting that we're talking about the heart. And it's a heart day.
Yeah.
And when you talk about heart diseases, I am a pediatrician. I must declare we think about heart diseases in children in two broad categories. Is it something you're born with, or is it something you acquire?
Congenital or
congenital. Excellent. Congenital when you want to sound educated.
Thanks.
Born with or you acquire. Right. So when you look at the general incidence, how often does it happen? We say about 8 in 1,000 live births will have a heart disease. About 8 in 1,000. We say that's the incidence. When we say 8 in 1,000, 2 in 1,000 will have serious heart disease that will die probably within the next 24, 48 hours after they're born.
Wow.
Right? So about 6 will live on for them to be diagnosed, for them to present in a certain way. So if there's sudden death in a newborn, one of the things in the back of your mind, was it a heart disease? So some may not be diagnosed depending on where they're born. Others will trudge along and will be found out to have a heart disease if they're in the right place and they have the right personnel who have the right equipment. Of course, the other bulk of the illnesses are things you acquire. And the commonest acquired heart disease in our setup is called rheumatic heart disease.
Okay.
Rheumatic heart disease is associated with the bacteria that's called streptococcus, which happens in the throat. And 3 weeks later, you begin to have other issues: the joint, the brain, the heart, the skin. Okay, but it is not really directly an infection of the heart. It's actually an immunological response to the bacteria that affected your throat. Okay, so it's a complex disease. It's not a direct infection. The streptococcus.
I'd like you to repeat that, because you have a problem with your throat,
And then your heart gets affected.
and then your heart gets affected.
Yes.
The relationship between this bacteria,
Yes.
the strep,
Yes.
and I'm not going to complete that name.
Yes.
Let's leave it with strep. And
Streptococcus.
yes, and how that relates to a process where now it's your skin,
Right.
it is other parts of your body,
Yes.
and then your heart.
Yes. I will just now delve you into a quick lesson in immunology.
Okay.
Now, immunology is basically the way your body responds to offending agents, right? In this particular situation, a bacteria. Your body produces antibodies which go to attack. They are scaries that go to attack that particular offending organism, right? These particular cells that go to attack recognize certain patterns of proteins on that particular bacteria. Unfortunately, sometimes it may mistake some of your tissues with the same proteins that are found in the bacteria. So it attacks your body, right? So it's a self-attack on tissues that resemble the bacteria. So it's a little bit complicated. It's an immune response. That's why there's a lag phase between when you get your bacterial infection in the throat and when you get a manifestation of what we call acute rheumatic fever. And we say it affects the joints. You get joint aches and so on, the large joints, and these joints move in sequence. Begins probably with the shoulder, goes to the elbow, goes to the wrist, goes to the hip. It's migratory joint pain. The other area that is affected but doesn't leave a permanent damage, it's transient. The other areas that are affected are the skin. You get a rash, a red rash on the skin. It's a little difficult to see in people of my kind of color. It's evanescent. It means it comes and goes quickly, right? The other area that is affected is the brain, your sort of cerebellum, where you find a child 3 weeks later is behaving unusually. A child who was writing very well begins to write like in hieroglyphics or something, you know, they're having all these sorts of movements and so on, or shaking or having all sorts of funny movements, right? It is really the effects of that response in the brain. But most importantly is the effect it has on the heart. It sort of causes inflammation of your heart tissues, all the heart tissues. The pericardium, which is the outer layer, the myocardium, which is the muscle, and the endocardium, which is the inner layer. So all the three layers of the heart are affected. They are red like this bottle of yogurt.
I'll tell you about that later. Don't worry. Just, you can use it as reference.
Yes.
But
They're as red as that.
Yeah.
They're red, they're swollen, they're oozy. And your heart as a function, as a pump doesn't work as well. Importantly is the inner tissues of the heart, which makes up your valves. And the valves are basically just that, just like the bicycle valve. They allow blood to get in and out, in and out. They get to swell. They don't move as well. They don't open or shut as well. So you get a leaky valve. If that is severe, that child may just die within the acute phase of that illness. Many of those will trudge along and will just they'll not die, but they are not functioning well. They can't run, they can't play, and so on. The heart gets larger and larger and larger, and they get other complications. They may not live their full lives. A few will have a disease that does not progress, but they live like that all their life. They are a little bit of weaklings, but they live on.
They get on. Okay.
So that's the rheumatic heart disease spectrum. Yeah.
Does that rheumatic heart disease also affect adults, for example?
That's a very good question. It's actually largely a disease of childhood. It's a disease of childhood. We say 3 years to 6 years. The incidence is highest there. That, like everything in medicine, does not mean because you are 32 you cannot get.
Yeah.
It's just unlikely.
Okay.
Yeah.
So usually, in the delivery room, the baby before that happens, the doctor will say, okay, I'm going to be there, and then we're going to need, a pediatrician in the delivery room. Yes. Because, of course, immediately the baby comes out, they want to have a look at the baby and make sure everything is all right. What would you see in that room at that point, or what would you look for? What would you do to ensure that this child then does not have a heart issue? Or are there things that you can see during the pre-birth scans and all of that would say, there's a problem here?
Yeah, that's a very good question. Now, prenatally, or before the baby is born, mothers usually go for antenatal clinics and so on, where they monitor the heart rate of the mother, the fetal heart rate. That's the baby who is unborn. The baby who is unborn is called a fetus. Once they are born, then they're a baby.
The baby.
So you monitor the fetal heart. Usually, the fetal heart rate is higher. Usually about 100 to 160 beats per minute. If your heart beat at 160 beats per minute, in 10 minutes you just collapse.
You're done.
Not survive. Yeah. So usually you will be able to track how the heart is doing and so forth. And that should be fairly easy to pick for anybody, including a midwife. There is usually scans done in pregnancy. And when they do the heart, apart from looking at the various sizes of the head, the limbs, and so on, they look at various structures, including the heart. It's important to understand how the heart develops. The heart develops as one big chamber that over time divides into 4 chambers. 2 pumping chambers, 2 receiving chambers. That means that this is a development that takes place over the pregnancy. So when are you doing the scan? At what point did you see this hole? Is this hole part of the journey of it closing? So it's a very dicey science that one has to take out a judgment call in perspective of the time of the pregnancy. But largely, when you have large defects, let's say the wall between the 2 pumping chambers did not develop at all. You can see the 2 ventricles are just one continuous ventricle instead of having a right and a left. So you would be able to tell gross malformations, right? Minor ones you may not be able to tell. If on the other hand you have blood vessels, and we have 2 large blood vessels that come from the heart, the one that takes blood to the lungs called the pulmonary artery, and the one that takes blood from the heart to the body called the aorta. We know the aorta comes from the left ventricle, the pulmonary artery comes from the right ventricle. Sometimes they are switched around. When they are switched around, then you are in trouble. We have what we call a parallel circulation.
That's a defect now.
That's a defect now, and that may be relatively easy to see. If you are to see that sort of a situation, then you are going to have to be making a decision that this baby, the moment they are delivered, within the next 48 hours, they will have to undergo surgery to correct that. Because those are some of the children that will die soon after birth if you can't. So you can't do anything about it. So do you have the capacity to do this surgery? It's called a switch operation. You're just basically returning things the way they should. If you're not, then tell this mother we are transporting you to a center that can do this operation.
What is the general, because you're looking at many heart conditions, and I'm thinking about the mother, and I'm thinking about how many Kenyan mothers in the villages, most especially, see the doctor at the point of delivery.
If that.
Yeah. How would you best advise a listener who's listening to us, who's a mother, she's not done her scans, etc. How would you best advise her to approach her delivery? Because sometimes they have no scans.
The first thing is we're trying to get everyone to deliver in a center where this qualification, right, where you're qualified. I know amongst the urban dwellers, there's this push to deliver at home delivery, because you know that's what happens in the Netherlands.
Bathtub.
Yes,
It's
a bathtub,
retro.
you know,
Yes.
it's cleaner and so on. That's fine when the ambulance can get to your house in 3 minutes and you have everything at hand. In fact, it's a fully mobile hospital. That's fine. We don't have that situation. Even in relatively good areas in town, vehicle may not be able to get there in time. But importantly, it's really the level of personnel that you have. First thing is to deliver in a place where you have a midwife. A midwife is able to pick out this is something unusual about this heartbeat. So get somebody else on board. And when that decision, because the decision is made from clinical suspicion, common things occur most commonly. Most babies are born normally, but it is that one baby out of 100
Yes.
that will give you grief, that will have a problem. So you deliver, I would tell a mother, make sure that you go for your antenatal clinics. If possible, most places now have what we call point of care ultrasound. In other words, it's a device like this that one is able, nurses sometimes are trained to be able to look and say there's something unusual here. If I see something unusual, I'm triggering the system. You need to go to a place where this can be done. And usually when you do that, and it begins from the healthcare personnel saying there is something I'm not too sure about, and there's something I'm not happy about, move to the next center. The next center then will keep on pushing you to the right person. So the first thing, responsibility for the mother is to make sure you've done at least your 4 clinics, antenatal clinics. If there is a history of a child or a baby born with heart disease, that puts you already in the red. I say there's history in the family. We need to have a high threshold of suspicion. If there is any congenital malformation, let's say, for instance, Down syndrome. Down syndrome is associated with heart diseases. Any chromosomal disorder can be associated with the heart disorder. So things that we call in medicine funny-looking child, funny-looking kid, dysmorphism. That means maybe the low set ears, maybe the eyes are too close, or there is something or other. Then you have to have a high index of suspicion. Could this be a chromosomal disorder, or does this baby look like the grandfather who died like 60 years ago? You know, that's how we explain things sometimes. Even when this gross malformation, you say,
He looks like somebody. Who looks like grandfather look like that? Yeah.
But that, unfortunately, it's really in the domain of health workers to be able to bring themselves up to speed, to be able to advise what you need to do. We get caught up with issues of cost. My work is to tell you what you need to do. If you think about cost and you will not do anything, you say, I don't know. I don't even know how to get a car to take me to the next hospital. But the moment you let people know, usually people are resourceful. Yes, you asked an important question that I failed to answer. What is it that I see in a baby that has just been born?
Yes.
And I worry. One of those is dysmorphism, funny looking faces, right? Is this baby syndromic, right? If you have a syndrome, you think about heart disease. Is this baby having blueness? And when you talk about cyanosis or blueness, it's centrally in the tongue. If you are sort of low oxygen tensions, in other words, your mouth is blue, your mucous membranes are blue, then you say, is this baby oxygenating properly? If this baby is breathing quickly and there isn't a clear lung situation that's explaining that, you say, is there something wrong here? If the heartbeat is high, it's higher than normal, or it's irregular, it's not beating in the way it's, you have a high index of suspicion. So you look at telltale things. If your pulses in the groin, you always feel for the pulses in the groin, in the thighs. If there is a difference between the pulse in the groin and the pulse, the radial pulse, the bigger pulses, then you say, is there something wrong? A condition we call coarctation. Sometimes easily diagnosed with just feeling your pulses. That's how we always feel the groins of the babies and so on. So there are certain telltale things that you can pick out. But it is in the next 24 hours that some of these conditions may come out. Others are obvious, others will develop over time, others will develop over the next 6 weeks. That's why we generally advise when the baby is born and everything is okay, you go home after the second, third day, we say we like to review you in 2 weeks because certain things may come out. There's a lot of changes that occur when a baby has been born.
This explanation you've given, is this knowledge something that you would only find with people who are medical doctors and cardiologists, or is it something or is this knowledge something you would find with caregivers who are nurses or clinical officers within a setting?
If they went through the system properly, they did not obtain their certificates in dubious places, that should be standard information. Medicine teaches you to recognize what is unusual, what you don't know. Something unusual, call for help. It's a standard way of looking. I mean, I said common things occur most commonly. Most things happen normally. Babies get born in the shamba and mothers go on. But it is that one baby that doesn't conform to that, that you are meant to be thinking about and saving.
Okay. We're discussing matters of the heart on our Healthy Friday conversation today with Dr. Dan Githanga, and we're asking, certain questions and saying, okay, so now how do we deal, with some of these matters moving forward? What are some things you should watch out for? And then, looking at Kenya as a whole. Dr. Dan Githanga is our guest.
David
Githanga is our guest.
My father is Dan, so that's fine.
Oh, so it's okay?
Any name goes.
Like how easy.
It's like I knew that your dad was called Dan. So I was just, transferring. But you're great. Thank you. And somebody's just actually texted in and said, I just tuned in to find out that my pediatrician from when I was younger is in the studio. Greetings to him. And his name is Kevin. I don't know. I think you've seen 1,000 young. So it's not possible for you to know who exactly it is, but you've touched somebody's heart all the same. And so we're looking at, I know.
You're quite poetic today.
I know.
It's flowing.
Something,
it's the red.
Something in the air.
No, it's a flowers.
There's something in there. So looking at these issues and trying to understand really, I mean, from your practice and then being able to say, what's the burden of, this poor heart health that we talk about in Kenya today? And is it being handled to the extent that that it should be to take care of these children? If we're saying that 2 out of 1,000, or 8 out of 1,000, are these numbers in Kenya?
Yes. Yeah. Yes. It's today in Kenyatta Hospital is Fridays when we run the Pediatric Cardiology clinic. If you go to that clinic, you'll be able to get a snapshot of the numbers. But remember, this is just one hospital. We now have cardiologists across the country, so some are going somewhere else. And those are the ones that have been diagnosed, the ones that have the capacity to be able to come to the hospital, the ones that have the knowledge to come to the hospital. So there are probably others that don't know. They just say this is just a weak child, or this one is a lazy child, and so on. Or this one is just as lazy as a grandfather who was always, we all have certain explanations of certain conditions. So it is a common problem for in pediatrics. Heart diseases. And do we have the capacity to handle? Yes, we do. For instance, let me go very quickly to rheumatic heart disease. It is something that we can prevent, right? We can prevent by making the correct diagnosis of a bacterial infection caused by streptococcus. Not all throat infections are streptococcus. But if you have streptococcus in your throat, strep throat, we must treat you. Because even if it's not going to affect you, you may give it to somebody else, right? So if we take a swab from your throat and cultured and grew it, we will treat you even if you are symptomatic, to save not just yourself, but even somebody else. So we can do something about that. When you're diagnosed to have rheumatic heart disease, unfortunately your valves have been affected, then we put you on long-term penicillin treatment to stop a recurrence of that disease. If you get acute rheumatic fever, you can get it again. It means there's something about you that gets your tissues to react that way to the streptococcus. So we protect you by giving you once a month injection.
What happens if you're allergic to penicillin?
Yes, that's a very good question. If you're allergic to penicillin, we have options. Unfortunately, the options we have are not injectable. And we know diseases that don't cause pain. For you to tell people to take medication, including even high blood pressure, it's very difficult. So compliance is usually not so good. We know that as adults, don't we? Yeah. The only time we'll take medicines religiously is if there is pain.
Right.
Pain gets us to take medication. So if you're talking about long-term, 15, 18, 20 years of taking medicines every day, oral medication, it's very hard. You will forget and so on. So in the unfortunate situation you are allergic to penicillin, then we would have to go to option number 2, which has those inconveniences. Fortunately, as you get older, the incidence becomes lesser.
Okay. Just a quick question, Dr. Since you said that Kenya has the capacity, many people when they hear about heart disease, they immediately go to the extreme of heart transplants and things like that, pacemakers, etc., etc. How available are these solutions in Kenya? I know that's the extreme side of things, but it's a question because organ donation in this country, I don't know how many people have even signed up for such things.
Yes, that is a complex question. Fortunately, it's moving away from pediatrics. Remember, some of the pediatric patients will mature.
Yeah.
Will mature and get older. A child who had rheumatic heart disease at the age of 4 years, they will grow up to be a 25, 26-year-old who is now seen by the adult physicians, adult cardiologists. Do we have the capacity? Yes, we do. We do have the capacity. We do have pacemakers. They're expensive. We can do basically most of the surgery, apart from the early neonatal surgery. Some of the complex surgeries, we may not have the abilities to do it locally, mainly because of the complexity of the issues and our abilities to handle 2.53 kilogram babies when they have complex abnormalities. Therefore, our roles are to make a diagnosis, make a quick decision. Does this child need surgery? Do they need palliative surgery? And palliative surgery means stopgap, waiting to do the corrective total repair later. Can that total repair be done here, or will they have to go overseas? Some of the very, very complex disorders, even in those developed countries, are only done in certain centers. So it's not just a question of you flying into a capital of the world and say this is the many skyscrapers. It's who is there. How many do they do? Do they have the capacity? Do they have the necessary infrastructure, the nursing care, anesthesia, and so on, to handle this kind of surgeries? Fortunately, in cardiology, we're all interconnected and we know who to take where and so forth. So do we have the capacity? Yes, we do. But the first step is always high index of suspicion, diagnosis, accurate diagnosis, and efficient referral. Cost is still a major issue.
Yes.
Cost is a major issue, and I do not have the solutions. I wish I did, but when the predecessor of Shah was working, it was able to lift quite a bit of that.
Yeah.
And I would want to say very quickly that a lot of heart conditions are amenable to surgery. Especially when they are structural, they are amenable to surgery. And you basically get operated. You have a hole in the heart, it gets sealed. You are brand new.
Okay, so that's what I was going to ask, actually, because it seems like, I mean, it's so delicate, right? This heart, it's so delicate, and then you're going to have to go in there and tinker with the thing, and just try and put it back together. But then it's central to operations for you physiologically. So then, what then is your quality of life after? I mean, you're talking about a baby, so they've not had too much time on earth, and you're newborn, right? But then, if you do it later, there's really no quality of life to compare with before, because you had the condition. But if you do it later as a child, if you can for however long you can stay, what quality of life are you guaranteed after the surgery?
Let me just first of all explain that a lot of heart conditions, structural heart conditions, are a spectrum of conditions. You can talk about a hole in the heart. Some holes are small, some are medium, some are very large. Some are so large that effectively there is no division between the two chambers. Those are still called VSDs, but they are actually very, very different versions of VSDs, ventricular septal defect, hole in the heart. Right? When you have a small hole in the heart, some are so small, they never make any difference to your life. You live a completely normal life. You'll actually be diagnosed accidentally when you're going for your employment check or insurance check and so forth. Others are so severe that they'll be diagnosed fairly early. So there are some conditions for which you need early surgery. There are conditions for which you can wait. Those that you can wait, you wait. It's about timing of the surgery. There are conditions for which, if you do not get an operation within probably the first week of life, you will not make it, right? It is the timing of the surgery, the expertise of the center, and your abilities to manage those things efficiently. And I'm not talking about cost, I'm just talking about competence. Right? So if you have a hole in the heart, and even if it is large and it's repaired, you basically are normal. You'll die from another condition, not the heart. Right.
Okay. So another one, that if there is what they're calling an extra heartbeat. I believe there's a medical term for it, but you hear that there's something subtle under there. What is that? And is that cause for concern?
Yes. It is, yes. Our heart beats regularly. Loop-doop, 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 loop-doop. Sometimes you're a little excited. You've had a cup of coffee, or it's Valentine, and on, or you have seen flowers, which are made in very interesting way. I've been looking at them. You get an extra heartbeat. So it's not always an unusual situation or a disease condition. But when it is persistent or repetitive, or you have certain arrhythmia, rhythm that is persistent, repetitive, then you want to be able to do simple tests to find out, is this one of those unusual situations? Your heart rate changes even with your breathing, right? Even with your breathing, the rate does change. And we call that a physiologic change. But you want to, if you feel your pulse, it's irregular, has that irregular nature got a pattern to it? Is it repeated at certain times? Does it disappear when I get you to exercise, for instance? Then you use that as your entry level to say we need a little bit more evaluation.
Right.
So a skipped beat doesn't necessarily mean that you.
And so I could see CT and my heart was skipped beating, but okay.
You're just excited.
Right.
You're just excited.
Okay.
You're just falling.
Right.
The three of you, are you aware that I actually am in this room?
You being here does not preclude us from saying what we want.
Okay.
This is what happens when you teach people more than one language.
So let me ask you another question that's coming from a listener this morning. Is that so? How does one know that they have an inflamed heart muscle, and what are the causes and possible treatment or management?
Inflamed heart. Wow. Inflamed heart means it's inflamed, means it's red, it's swollen, it's oozy. What is causing the inflammation? What is causing the inflammation? And if you're going to say that it is the muscle layer of the heart, it's called the myocardium, myocarditis, it's inflamed. What is causing it? There is definitely a problem. If your heart muscle is red, swollen, it will not be working well the way it should. So it's a serious condition. If you are going to say you have myocarditis, is it viral myocarditis? Is it something that is transient that will get better, or is it something that we need to look out for? Some of the viruses cause inflammation of the heart, and they leave you, if you survive that period, they leave you with a flabby heart, right? It doesn't work as well. It's lost its contractility, its abilities to pump. Right, you get what we call a cardiomyopathy. Cardiomyopathy means that it's not working well. It's becoming like a bag of fluid that doesn't work well. So those are some of the patients that will survive with difficulties. Those are some of the patients that may require heart transplant, which was asked. A question that was asked by Mark. Heart transplants can be done. But a heart transplant is not an everyday procedure. First of all, unlike a kidney, where we have two, we can donate, you only have one heart. So by the time that you're donating your heart, it means that you probably died violently of an accident. You're in the right center. You are within a certain space of time where that heart is going to be removed, harvested, to the person who is requiring it, who requires to be ready. It means the two of you or the matching of the patient waiting for the heart transplant will have to match this particular one. So the abilities of testing that heart has just been harvested, matching with the other one. So it's a very dicey, narrow window, narrow opportunity sort of a situation, not something that is done every day.
I'm interested.
Yes.
I'm interested in this. You mentioned the word transplant.
Yes.
Since we're talking heart.
Yes.
Do we witness many situations where children actually undergo a heart transplant?
Yes, but not in this country yet. Not in this country yet.
Okay. That's question number one.
Yes.
There's always a preventative aspect of healthcare. Now, when you work or you specialize in an area such as yours, because the mention of the heart sends trepidation. The mention of the heart not doing what it's supposed to do signals a journey that you'd rather perhaps not make now. What is it that people with your level of expertise tell parents, mothers, parents of young children, wannabe parents, to do so that they can prevent conditions such as the one that you end up treating? That is, if they can be prevented.
It's a very difficult question to answer in one sentence. But generally, children are meant to be cared for in total. Whether it's about their nutrition, whether it's about the behaviors they engage in. And by the way, nutrition is very, very important. Today, other cardiologists tell us that we are creating patients for them when we allow them to have certain dietary habits over a long period of time, right? And healthy foods and so on, sugars especially. Those are being queued up for diabetes, hypertension, and so on because of the high salt intake, fast foods, and so forth. This, you do not grow up healthy, and then you end up with a condition, but into your adulthood. But they are saying that this begins quite early. That's why feeding habits in a home are important, because you become what you eat over a period of time, and those habits are difficult to change when you get older. So there are things that relate to proper care of a child as they grow up. Do they exercise? Do they run? I mean, we are in serious danger of people now spending all their time just on gadgets and so on. They lose their abilities to communicate, and they lose their abilities to play and exercise and, get that kind of a lifestyle. They want to sit in front of a large TV screen. And that will definitely predispose them to the NCDs that Ndu mentioned about a little bit earlier. So as a pediatrician, I say, let the child move, let them go and play and so on, let them eat right and so forth. Let them have a regular review. We want to see children up to the age of 5. How are they growing? How are they developing? To be able to detect the subtle things, neurodevelopmental things. Heart conditions that are severe are relatively easy to pick.
Okay.
Right? They are relatively easy to pick.
So then on that note then, Doc, there's another question here, and that, it's, I think, pointing to that we sometimes sit with symptoms, scarily even with children, and that a child who breathes pretty heavily and that will run for some time and then get very tired very quickly. Taken him to hospital twice, but they say that it's something that he will grow out of. But sometimes he is uncomfortable, and I'm not quite sure what to do.
Yeah. When you get, we call it shortness of breath.
He's 6, by the way. Yeah.
Yeah. Shortness of breath. We can get short of breath because of purely being unfit. I climbed up the stairs. I'm a little breathless.
Yeah.
Yeah. You're not necessarily, it's not a heart condition. It's just that's why you're moving and so forth. Yes. So fitness. Then what level of exercise gets you to become
Be
breathless?
out of breath.
If many of us are asked to do a 200-meter dash around the field
Today? Okay.
yes, many of us will be breathless. Yeah, that doesn't mean you have a heart condition. It just means that we are not fit. The other major areas where children will get short of breath is exercise-induced asthma. Asthma is a condition that is people fear asthma, but I like to joke that your airways by their very nature are asthmatic, right? Your airways, if they're irritated,
They constrict.
That's the natural reaction. Your gut does the same too. Yeah. So when they constrict, you tend to cough to open them out, right? So people who are allergic and so on will have a little bit more of that. So there are subset of patients that will have exercise-induced asthma. The moment they begin to run, they begin to cough, right? Because the exercise induces bronchospasm. That means closure of the airway. So very often that can contribute. But many times it's just fitness and so on. The very fact that you think about the heart condition sometimes causes a lot more anxiety than it needs to be. Last week I saw a child whose mother was very distraught because they had gotten an x-ray for a particular condition. They are told your baby has a heart condition and needs to be admitted now. I mean, there was an emergency created round about what I call non-issue. But and that depends on how that message is delivered. And when people hear a heart thing, they think of a heart attack. Heart attacks are largely things of us adults or people who have certain conditions. Children rarely get heart attacks, right? It's coronary artery disease is an acquired heart condition for adults. Children don't get that. And yet when we hear about the heart, you think about sudden death. For us, yes. For males, yes, more than for the females, right? Yes. When you're male, you're more prone to that sort of a situation.
Can you give the males some good news?
But that is good news.
That you'll suddenly die.
Yes.
So be careful.
That you'll suddenly get a heart attack.
Let me just shock the two males in the room.
Oh, here we go.
All our lives, boys or the boy child has a higher risk, whether it's behavioral or even disease conditions, right? You are likely to engage in sporting activity that's risky, ride bikes and so on. That's risky, even as a little boy. And when it comes to heart conditions, yes, they are more likely to get, by male gender only, you are more prone to getting heart attacks than female. And I must add a little joke here that once the girls also become males, in other words, when they get to the menopausal age, they now have the same risk.
I've never heard that in my life.
You didn't know you were going to become male until the 14th
In other words,
of February
they lose
2025.
the advantage of the estrogen.
Right.
Estrogen
Okay.
tends to protect them. Yes, that's
To become male.
yes.
So you also get
Light
prone. Yeah, of course.
Yes.
So there's something that I heard about muscle wall thickening.
Yes.
Due to high blood pressure and things like that, and there are a few people, especially as they get older, will go through that. Could you just explain that a bit more?
Yeah, the heart is a muscle, pretty much like people going to the gym and so on, pumping iron. That's what I hear them calling the real muscle.
Yes.
The heart too does behave like that. If the heart has to work hard because of increased resistance upstream, right? The heart has to pump across vessels that are narrow. Then, of necessity, the heart walls will become thicker, right? It's called hypertrophic. Hypertrophy just means thickening of the walls. You get that. And that is a secondary effect of the high blood pressure. It's a lot more complex. But of course, you can have certain heart diseases that you're born with, cardiomyopathies, where you have hypertrophic heart disease. The heart muscle is very, very, very thick. If your heart muscle is very, very thick, it means that your cavity is it's smaller. You do not fill up as well because this muscle is too thick. Your heart needs to open up, fill up, get blood, pump out. But if it is too thick, then you have a problem of being able to pump, to deliver blood when the heart is pumping out. Then number two, the supply of blood to the heart muscle itself is compromised. And that's how you get what you call your angina, the pain in the heart, because of the insufficient blood supply to the heart. So if you have hypertrophied ventricles, then we are saying, why do you have hypertrophied ventricles? You have to look for the conditions and manage them.
Oh, so it's not heartbreak.
No.
Okay.
Yeah, so if in case you haven't noticed, Mark is a bit worried about heartbreak today. So maybe we can actually just do that real quick, because folks have been saying, is there actually a physical condition that can be likened to heartbreak, that literally your heart has fallen apart?
Physical condition. I guess you can get a catastrophic situation that your heart behaves in a particular way and you can get an arrest. If you have what we call a vasovagal attack, you sort of stimulate the vagus, you can get into sort of the heart stopping, right? It's called a bradycardia, or low heart rate, because of certain stimulation of the vagus nerve. That can happen. But generally, it is not in the ordinary sense of conversation. You have a heartbreak, the heart has broken. No.
Yeah.
David,
Yes.
when you are upset
Yes.
and you feel a pain in somewhere where the heart is supposed to be,
Yes.
what on earth is that pain?
You need prayer.
Because I've felt that pain.
Amen. I think it's right.
Exactly. And I think that's a great place to end on today. Thank you, Avin, so much for talking matters of the heart with us this morning. Dr. David Githanga on this Valentine's Day. Matters of the heart, important matters. Consultant pediatrician, cardiologist, thank you so much. Pediatric cardiologist, thank you so much for being here with us this morning.
This is the Situation Room, the only way to start your day.